Welcome to the Physician's Guide to Doctoring, a practical guide for practicing physicians. Dr. Bradley Block interviews experts in and out of medicine to find out everything we should have been learning while we were memorizing Krebs cycle. The ideas expressed on this podcast are those of the interviewer and interviewee and do not represent those of their respective employers. And now, here's Dr. Bradley Block.
Today's podcast is sponsored by Thermal Custom Packaging. TCP has many different products to help with medical transportation, including their totes and phase change materials, or PCMs. TCP developed a portable blood bank using these phase change materials to maintain the precise temperatures required to store and transport blood. This portable unit allows blood to remain with the patient in the critical hours following surgery, which is especially important with younger, smaller patients. Using TCP's insulated totes and their custom PCMs, they're able to transport blood specimens, biological pharmaceuticals, tissues, organs, vaccines, including the COVID vaccine, as well as allografts, refrigerated, frozen, and ultra-cold as needed. These products are even being used to ensure the safe travels of the COVID vaccines to rural areas. They also have other products such as MedShield and IceBuddy available for retail use, which you can learn more about on their website, which is thermalcustompackaging.com. Visit them with the link in the description for more information and follow them on Instagram at thermalcpackaging. Dr. Brian Cohen, thanks so much for being on the podcast.
Brad, thank you so much. Long-time listener, first-time caller, been watching you since 1993. You and Delilah, my top two shows, so super excited to be here.
Appreciate that. The date seems right. I had just finished middle school.
Right, exactly.
I think my bar mitzvah was that year. So your bio state. I'm going to start with a question that I hadn't listed. Your bio. It's not really a question. It's more a comment. Your bio states that you're the father of two amazing daughters, which makes me feel really a little badly about how I describe my boys on the show. Like, two of them routinely bite their toenails. They bite their toenails. So, I now need to come up with a better adjective when I'm describing them. I'm sure they'll be amazing eventually.
As fathers, we all know that everything goes in phases. And I think to completely stereotype gender and raising boys versus girls, I am entering, my girls are 9 and 11. So I've had that wonderful, opening stage of life, and I'm about to hit it, man. So everything that you've dealt with for the first 9 to 11 years, I'm about to get with a vengeance for the next, 5 to 6. So
good luck to you, sir. Good luck.
Yes. Thank you. Thank you.
Okay, so before we get to Adaptrack and CMEfy, which are going to be the main topics of the discussion, what's a concierge anesthesia company? What is that? What's concierge anesthesia?
It's funny you ask me that, because that's been the way we've described our anesthesia practice for the past 7 years, and I think you're the first person to actually ask me what is a concierge anesthesia practice. The answer is pretty simple. It's probably what an anesthesia practice should be everywhere.
Okay.
What we saw in South Florida, the anesthesia world became very corporate very early on. As everything in different specialties in healthcare sort of goes in that ebb and flow over a 10-year period, from private group to hospital group to large corporations. South Florida anesthesia was the birthplace of Sheridan, which became Envision, and Mednax and USAP. They were all headquartered here in South Florida. What that did in our eyes was take away some of that personal touch that exists in medicine. And because of a 100% employee-based model, there was a little bit of that, you lost a little bit of that incentive to just go above and beyond. And so when we ventured out to start our own anesthesia company, it wasn't like we were revolutionizing what we wanted to do as far as patient care and surgeon relationships and administrative relationships with our facilities. It was literally what should have still been done everywhere. but we felt like it was lost a little bit. So concierge became, really just taking it back to everything it should be, very high touch. When you have ownership in what you're doing, and I think this has followed through with everything I've done, is I'm a huge fan of being incentivized in the right direction with all parties. When we had ownership and skin in the game with our anesthesia company, it wasn't like we could go to a surgery center and do one case as opposed to 100 cases and make the same amount of money. If I was employed, I could go and I could do any amount of cases I wanted. It didn't matter. I was going home with the same paycheck. So when we started our company, when we went 7 months without a paycheck, when we were starting up the hospital, I guarantee you every potential case, I remember one case from, it was a foot and ankle case from Guatemala. And I got on the phone with the patient's cardiologist in Guatemala to talk about cardiac clearance, because I was not going to let this patient leave without getting what he had to get done. And again, that was a little bit because it was the right thing to do. It was a little bit because everyone's incentivized to perform as opposed to push things off. And that's really when we set that as our culture, and made sure everybody who was joining us and everybody we were partnering with, felt, believed, performed the same way. That's what's allowed us to survive down here in what we call kind of the belly of the beast of these large corporate companies, where we are the ones that actually are still incentivized to perform at that level that we think is whatever you want to call concierge.
So maybe a boutique anesthesia firm or company or practice. Yeah.
Yeah.
Like high touch, it's small, boutique, but you might not want to call it boutique, because then that seems a little maybe trite or
yeah. I mean, I think also in medicine,
service.
Yeah, no, I agree. And I don't know what the magic word is, but I do know that, I mean, as we've grown in healthcare and as we've become, when you look into the large health systems and between specialties and just having the consults or, working a patient up towards surgery, and that path between preoperative assessment, maybe the internal medicine clearance, the consult to the cardiologist, and when they make it to the anesthesiologist and the surgeon, we oftentimes lose that personal one-on-one conversation that actually, from a risk point of view, makes a huge difference. From a patient care point of view, makes a difference. And I know when we go in, for example, with an ENT surgeon or any surgeon, when we have that conversation one-on-one, it's important. And when you move outside of that kind of high touch, whether it's between myself and the patient or myself and you're losing an aspect of medicine that's still pretty important to have. And half of our healthcare system has moved in the direction of an employed model and half hasn't. And there's pluses and minuses to everyone. And it's about, finding what's right where you are and making the best of it.
Well, you're speaking to the choir here, right? Because I have a podcast that like a third of the episodes are about communicating with patients and communicating with colleagues, mostly patients. So yeah, I get what you're saying. It sounds like it's even a patient safety issue. Like you're motivated to have more communication with the patient, have more communication with the surgeon, and that can only lead to better outcomes.
Yeah, absolutely.
So you're the chief of the MSO. So anytime I've ever heard about an MSO, it's been as a way to take the management out of the practice so that it can then be bundled and, say, sold to private equity or sold to another healthcare management company, as a way to simplify outsourcing. So what you told me before the show, that's not really the case with you guys.
Yeah. I'll sort of tell you the path that took us even to forming an MSO that we didn't even know. I had to Google, the 3 letters before we decided what we were even doing. And I think it all stems back to when we decided to actually go out on our own and form the anesthesia company. We were under the assumption that this is something like people do all the time. Like there's a playbook, kind of like when you have a baby. We get that playbook when the baby's born, right? It tells you how to parent. Much of the same manner, there is no playbook for starting an anesthesia company. But then we figured at least there's people out there who can kind of point us in the right direction. Going in network with payers, just the logistics of the everyday back office flow. And again, we were kind of finding that, there's billing companies, there's billing and management companies, but when you're starting off on a small scale, they're not really touching you with the level of service you need to actually get off the ground and survive and say, okay, I'm ready to actually do a case at a facility and bill for it and collect. Our first, year of practice, we sort of just fumbled through that until we found the right formulas. We leaned on mentors, we leaned on people in the industry, but it was really just kind of putting those pieces together in order to form what we had. In the process, I don't think we were truly aware of some of the other important factors that were lining up for us that would be important for long-term success and life of a group, as opposed to just that pure survival treading water moment that we always felt like we were in. And that was the process of getting in network with payers. When we started our company, again, we were 4 anesthesiologists, had done 0 cases as a company, had 0 history as a company, had never billed a case. So to go and say, hey, United Healthcare, my name's Brian, I've got a company, Miami Anesthesia Services, what's our contracted rate? They don't answer the phone, let alone have that conversation with you. So there are a lot of rate limiting steps in order to go towards that in-network process. What ended up happening with us is we were starting our group right at the same time we were participating in the startup of a physician-owned surgical hospital in Miami. So for good or bad, that hospital had to go and network with every payer as well. And we literally said, okay, Cigna's coming today. Yeah, okay, thank you. And we'd go and knock on the door of the boardroom and say, hey, Brian Cohen, nice to meet you. Miami Anesthesia Services. We're going to be providing services here. We'd love to, speak with you as well about getting a contract. And lo and behold, over that first 12 to 15 months, every time the hospital went in network with a payer, we followed them. Again, not truly appreciating what that was doing for us. It was pure survival at the time. But what we found after kind of that initial 12 to 15 month period is, we've got kind of buddies out there in the anesthesia world, and they'd say, hey, we saw you guys started a group. We have an opportunity at this surgery center, for example, and the surgeons want us to provide service there, but we don't have a company. Well, it's easy to form a company. You go online and you get a name and your tax ID, but the hard part becomes everything I was mentioning before, that back office part of it. So what we ended up doing is, taking all of the legal documents, all of the even day-to-day documents, OR records, contracts to give to your employees, policies and protocols, and putting that together and really creating a anesthesia company in a box, and allowing other independent groups to partner in with us to take advantage of what we had suffered through for the first 15 months of our existence. And it's been very rewarding because, again, you see yourself in a lot of these other people that are out there doing what they think is really the right thing in the right way. You become very intentional and very picky about who you partner with in this, because they also become an extension, of you in a way. And we've really found some very strong relationships. It's allowed us to grow with some of these other independent groups, and it's been a way to, again, in medicine, if I sat there and did, anesthesia all day, and that's all our company did, you become somewhat limited in your growth pattern. So this was another way sort of for us to grow and expand our footprint. You mentioned with what the typical endpoint or end game is when you go this route, and we're in a funny place. The whole reason we started what we started was because we were the anti that. We wanted to get away from the mentality of kind of that clock in, clock out, approach to medicine, and not that that's what every situation is when you're going down that pathway. However,
you've now built something that they want, right?
You have, and the key I think that we will always have is trying to hold on to a piece of that as well. Again, I think if we are not incentivized in some way or form, then the wheels fall off the bus. That's why I think PE companies have sort of shifted into that model of what they have now, as opposed to just in the anesthesia world, take the Envision model or Mednax, which is now doesn't exist anymore, probably because of that, where they buy you out 100%. Now I have zero skin in the game. US Anesthesia Partners started allowing physician owners to hold equity after purchase. Other PE companies sort of now have, obviously that follow that path where you leave some equity in your group and you leave some skin in the game. Is that what we're after? Honestly, but my partners, we all have young kids. We're young families. We're in the middle of our careers in our mid 40s. What we like about what we're doing right now is we have control over what we're doing. We get to partner with who we want to partner with, meaning saying no to surgery centers that we don't believe that things are being done in the right way or is a good fit with our culture, bringing on the employees that we think are a good fit with our culture, and having the freedom of our day-to-day really scheduling in life and finding that kind of work-life balance. Is it worth getting a check to give all that up? We've decided no right now, and I think the answer is going to be no for a while, because that's what's important to us right now.
One of the causes of physician burnout is lack of autonomy. And so once you sell, you give up a piece, if not all of that autonomy. Maybe you have a percentage in name, but you still can be told what to do. And so you guys are protecting against that by owning the company and managing the company.
Yeah, I mean, it's really interesting, because I've been in almost every different practice scenario. When I came out of residency, I joined a private group that ironically they became one of the first groups that joined USAP down the road.
Huh.
When I was with that group for the year while my wife was finishing her residency, these guys were amazing. They were what I thought every partnership group in the country was. I mean, they had each other's back. They were business savvy. They were amazing clinical care. They were everything that we should be. I'm like, okay, well, anesthesia is great. This is going to be nice. And then I came to Florida and I joined another private practice. And I mean, I can openly say it was the exact opposite of that. And that group ended up selling to Mednax. I was the next in line to become partner in that group for 5.5 years. So they were never taking new partners. And I got to feel what it felt like when you were on the outside looking in and watch that transformation of what happened to the style of work and the style of the group when that switch happened. And then I stayed in that group for another 3 years, and that's when then I came out and started my own group. And over these settings and over the years, and I've talked to not just people within the anesthesia world, but other specialties as well. My brother's a retina surgeon. He just went through a deal with a PE company, and every single group has their own unique factors. I mean, and so I kind of said, I just told you kind of where our heads are at. That's just us, and that's just where we are. And I don't know that there's a right or wrong or anything right now. I just know that every group is so unique. And where it gets really interesting is when you have the guys who are at the tail end of their careers, and you have the guys at the beginning of their careers, and you have those in the middle, and you're going to come to a decision. Those are scary conversations, because I don't know that everybody can win, in those conversations, because
that's my practice.
Yeah, it's hard. It's really hard. It's so where we are at, I'm lucky that I found two partners and we found each other. We didn't really know each other going into this, which is amazing. Where our priorities align. And I think that's super important when you're looking to join groups or looking to stay in groups or anything like that.
Well, somehow within building this practice, being the chief of the MSO of the practice, you also managed to build and be a partner in a digital health company. So pretty amazing. So let's talk about, I think the evolution, right? Correct me if I'm wrong, is Adaptrack and then CMEfy. So it would make sense to talk
Correct.
about Adaptrack first.
Yeah, no, you're absolutely right. Going back to the beauty of having very good partners in anything you're doing is, even though I was acting on the admin side and the clinical side, and we had our own group anesthesia company, and I mean, loved every second of it. I still had an itch to kind of, I don't know, look around. I had been in that employed model for so long, I didn't know what existed, outside of the hospital that I had been at for the past 8.5 years. And I started to sort of see what physicians, where our minds could be offered throughout, the rest of, whether it's the rest of healthcare or business or just other opportunities. And I had not really looked outside of that because I existed in that bubble, at the time. So once I got outside that bubble, the first thing I said yes to was a medical malpractice company that's executive branches based out here in Fort Lauderdale called AMS. And they asked if I'd be their specialty medical director for anesthesia and pain management. And so I actually started doing that right around the same time we started our anesthesia company. And it was, something that required, a couple hours a week at first. But as I started getting into it more and more, I started wanting to do more and more with it, where I said, I'd like to dedicate a day a week to this. And my partners, we figured out how that would happen. And it not only did it allow me to sort of look at what I was doing with my anesthesia company and the clinical side in a little bit of a different manner, meaning from a risk point of view. But it also showed me that, God, man, I don't know, being in the OR 5 days a week and at the grind maybe isn't for me. And maybe I am finding a little bit of balance out here, and maybe this is good. Again, my partners could have easily said no to that. So every day I'm thankful that we have the relationship that we do, and they let me kind of play around in this world. And my experience in the medical malpractice company led me to the introduction to two other partners, which was really the birth of AdaptTrack. And what happened was, in medical malpractice, I started to see risk and how risk was, there were trends in what was happening. Meaning, if I looked at malpractice cases, there's the same top 5 that are happening in this specialty over and over and over. So now I can go back and I know those top 5, and I can tell my partners and my employees, hey, we need to be careful of this, 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 and this, because this typically will lead to a lawsuit and a poor outcome. Okay, great. I just shared that, what we would call blind spot with my own group, and now we're better because of it. So
you didn't just push those cases on them.
Oh, man, that would have been so much easier, Brad.
You know what, guys? I'm not going to be here on Tuesday.
But remember,
I'm sorry. Yeah, not going to work.
Yeah, when we all share the malpractice policy, it becomes harder. But again, I was fortunate enough then to meet Niraj Swami, who was brought in really by mutual friends of the CEO of one company and the medical malpractice company. And Niraj was already, spent some time looking at using technology to change behavior for the better. So when I saw what he could do from a technology side, and when he listened to what we were looking at from a medical risk side, we said, we're doing something together. The next question became, well, what are we doing? I never really ventured into this digital health world or tech or anything, but I had started to appreciate the ability to problem solve from a product standpoint and from a flow standpoint, coming from the startup of the anesthesia company and the startup of the hospital. And what we found, and this was 2018 leading into 2019, there were a ton of apps out there. There were a ton of tools in healthcare, obviously, but there weren't that many for physicians. But there was all these tools for patients, tracking your diabetes, better habits. There are all these apps for EHRs and health systems and hospitals, but there weren't that many that were there to actually benefit a physician or the clinician or anybody that was out there doing
That's
care.
around the time that my podcast started, and there were not that many now there's a ton. And as I've said before, I don't appreciate the competition, but like at that time, there were not that many that were geared towards physicians. Everything was patient facing because that's the biggest audience.
Right.
But
back in 93, right?
There's value back in 93. Back
tell
when
me about it. I know.
it was
So
my Commodore 64.
That's right. So that really became my focus and my job within AdaptTrack was we're doing something that's benefiting us. And
sorry. Could you elaborate? What is Adapttrack? Tell the audience.
So what we ended up creating was a digital risk awareness tool. So taking what Niraj was doing with human behavior and technology and taking what we were seeing with risk, we thought there was a way to essentially present micro learnings to physicians in a way that essentially presents them the blind spots that exist in practice, where they become more aware of that and over time change their habits and behaviors in a less risky way. Now, that doesn't just happen. We don't just log on and read stuff for the good of our people. We have to be tied to an incentive. What happened was that incentive became continuing medical education credits for us. So now we had an incentive out there for physicians to engage. And the next challenge became, how do we want to engage? I don't want to sit and read 50 PowerPoint slides. I don't want to sit and read 3 pages. I don't want to sit and read literally a paragraph. Like, I want like 3 sentences. Tell me how not to get sued on this case and let me move on with my day and give me that CME credit for doing it.
I don't even want to read their sentences. I just want my eyes to be closed and someone to whisper in my ear.
We did that too. So we did audio, we did video, we did, text-based. You could speak it, you could text it, you could write it, you could listen to it, you could call on your phone, and essentially on your ride home, you could listen to your risks and reflect on how those risks will apply to your day-to-day, and you earned your credits.
Okay, so these are specialty specific courses. So what you guys do is, because I apologize, I'm not quite understanding, is you go through the trends of medical malpractice. These are the things that people are getting sued for in your field right now. This is what you need to know. And then in order to get the credits, you need to reflect on that. And what reflect on that means, we're going to get into in more detail in a little bit.
Exactly.
Okay.
It's exactly right. And the way we bring it into specificity is through the NPI number. And again, it was a refinement process over the first few years to figure out a tool that, number one, benefits the people in the middle that are doing the clinical cases and work, and number two, get it to them in a way that is how we want to engage and absorb this information. We didn't want to give anybody one more thing to do. And over time, AdaptTrack has become more and more purely risk focused. It was able to bring in risk out of 3 categories: clinical, administrative, and personal. Personal centered around burnout, administrative was documentation risk, and clinical is just what it sounds like. And now that has really bucketed itself over to the side in a risk category that malpractice companies, appreciate and use. And it also became, really the birthplace of CMEfy.
So that sounds like, hey, we're creating all of this content for people to consume and get credits for, but wait, other people like this Brad Block guy is out there also making amazing content, and we can use those and they can do the same thing to get CME credits for their listeners.
Yeah.
So we don't just need, you guys don't need to be the content producers anymore. You just be the platform that we use.
Correct. And it became less about content. And this is where we kind of have to shift out of what we're used to in the CME world and in the learning world. And I'll take one step back, and what really triggered, that transition from the pure AdaptTrack user experience as a web-based application to CMEfy was the pandemic. And Clubhouse blew up during the pandemic.
Is Clubhouse still a thing?
I don't think so. I don't know. Yes, it is. Yes, it is. But I haven't been on in a while. But at the peak, it was amazing. It was thousands of people on a 100% audio-based app where you were listening and learning with each other. And being in the healthcare world, you could easily delve into that healthcare space within Clubhouse. And we logged on there and we said, oh my God, there's 1,000 nurse practitioners in this one room talking about this one clinical case and learning together. Why aren't they getting credit for this? And the challenge then was, how do we bring that previous experience into things that are already happening, into learning moments that are already taking place? And that's when CMEfy, which is purely a technology tool, brings CME content into the moments that matter to us, that we're already having. And the premise is, what we realized is physicians, we are learning all day, every day. Every conversation we have, we're learning something. The setting in which we're learning it is not, we're not forced to be in the traditional classroom anymore in order to learn something.
So I get that we're consuming content in all different places, right? What I don't understand, because the AMA is the one who regulates what gets CME credit and what doesn't get CME credit. So what is it that they've decided gets credit? Because it's not, right, listening to my podcast is not what gets credit. It's this reflection that you guys keep talking about. And so was that something that you had discussed with someone at the AMA and said, you know what, we're going to create this new way to decide that someone's learned something? Or was this already present somewhere in their decision-making for what qualifies as credit, and you guys just extracted it?
Sure. Well, so with the AMA, I mean, you have internet point of care credits, and that's what CMEfy brings in. CMEfy brings in CME content and allows you to reflect on how that applies to you in your day-to-day. And that's what generates the credit. Internet point of care credits have been around. That's what UpToDate is. That's what Doximity is. I don't necessarily need to live in my EHR where UpToDate is. I don't necessarily need to only learn from an article one of my friends wrote in on Doximity. I can learn elsewhere. I can do searches elsewhere. I can engage with learning moments anywhere, and I am.
Appreciated, but sorry, I just because we're running a little short of time, so I'm trying to get what CMEfy is all about. And so let's use what our discussion about, say, the MSO as an example. If you were going to create a CMEfy moment for this episode and wanted to use the MSO, what would I do?
So what we did with CMEfy was built this technology tool that essentially allows, let's say you as the podcaster, right? You as the host, and you have your host account. Everything sort of lives with a link. So you have your hosts and you have your learners. Your learners are your listeners, right? They're listening and learning from you and your podcast about the MSO and our discussion. They need to access this link in order to click on it, engage with this piece of content that has been CME accredited, and reflect on it. And by reflecting, you're prompted to do two things now. You're prompted to reflect, what did you learn? And what are you going to do with it? How are you going to apply it? You're reflecting in and you're reflecting on. Those reflections and that entire process is what generates a half a credit of CME each. So for you as a host, if you, on this podcast, you're going to have a link, a CMEfy link, any listener can click on that link after they've listened to your podcast, and they can reflect on what they learned. They can apply it to them. They can apply it forward to their peers, their colleagues, and those reflections are going to each generate a half a credit of CME. Those reflections are also going to live in their learning journal forever, so they can go back and see what they've engaged with and what their thoughts were on it, how they plan to apply it. That learning journal is also where they claim their certificate, print their transcript, do anything they need to do. In addition, those reflections that they leave can anonymously come back to you as a host. So now you as a host, you say, okay, I've got 40,000 listeners to this episode, right, Brad? And 39,950 just clicked on that link because they felt like they really learned something from engaging with this, and they're going to apply it to themselves and apply it to their peers and talk about how, they can use this, and they generate these reflections. Now, you as a host, to get back 39,950 reflections, that's a lot of information, and that's a lot of data anonymously. But that's you get amazing insights as to what your learners, your peers, your colleagues, your listeners actually care about.
Yeah.
How they're going to use your information. And that's where this tool starts going from really this peer-to-peer, clinician-to-clinician tool to all the way up to the industry side of health systems, organizations, entities that really are challenged right now on two things. They're challenged to get engagement from their clinicians, and they're challenged to really know what the hell is going through their heads. So, say I'm the head of a 5,000 person specialty group, and I've got a new policy to push out. I can send an email. Did anyone read it? I don't know. Do they care about it? I don't know. Do they agree or disagree? No idea. I can send that. I can attach a CMEfy link. I can now track whether or not they engage with it. I can entice them as a currency of engagement with the CME. Now they're more likely to actually engage with the email, read it, because by reflecting on it, they're going to be able to earn credit.
Well, sorry, the reflection.
Mm-hmm.
Yeah, the reflections. That seems something that's pretty easy to game the system, right? Like,
Mm-hmm.
What did you learn about MSOs and how does it apply to your practice? And their answer might be, I need to eat more sandwiches, right?
Yep.
And so what's to stop them from doing that and then getting CME credit for that? That being said, just to compare it to the current system, you can also sleep through grand rounds and still get credit for it. So it's not like someone's vetting all of our CMEs here.
Yeah, so you're spot on with both of those comments. So how do we police against it? Number one, we really haven't had to, and I'll give you some numbers that explain why. Number two, we do have AI built in that essentially says, literally, if you say, I need more sandwiches or I like chicken Parmesan, it's going to say you need to leave something meaningful in order to earn credit. There is a word minimum, but I think we're at 8 words or 9 words. But amazingly, we have over 25,000 reflections now. The average reflection is 21 words long. So what we've seen, and I think this is part of it that makes me super proud about you, me, and the rest of us out there practicing medicine, is when you present something to us that's already a benefit to us, we're not there to knock it down and to game it. This is something that's presented in such an easy way. And think about it. Everything is opt-in. I could listen to your podcast. I don't have to click on a link and get credit. I'm only doing that if I want to. If I opt in to do it, that means I'm engaged and I'm there for a purpose. And when people go there for a purpose, people are leaving some pretty incredible stuff. And again, 25,000 reflections in, I could count probably on one hand how many that said, like cool or something and got kicked back. Now, that being said, what you also mentioned is totally true. And what we found is most of these tools out there, you sit through an hour-long lecture, they ask you, how was the room? Was it too cold? Was your turkey sandwich good? Check this box. That doesn't tell me anything. And that doesn't, what we really, and to be honest with you, when we started with AdaptTrack and when we started with this type of reflection model, we had 3 options to give as a response. You could check, this was great. I plan to apply this to my day-to-day. This is useful, but it's not useful for me, or I don't plan to apply this. And then free text. And over 90% of the people free text. And we got rid of the boxes. So it's been something where, again, this day and age, it's a very natural response for us to click and type. Most people are doing it on their phones. Over 90% of people are doing these reflections on their mobile devices, and it's literally like texting themselves, and it's living in their journal. So there are barriers up to prevent the gaming in the system, but amazingly enough, they don't even really need to be there.
Awesome. So you can apply this to the individual content creator, right? Like myself, I can sign up for CMEfy. And it's really low cost. You can sign up as a big practice. So I'm actually partner in a huge ENT practice. When we start doing in-person lectures again, or even not necessarily in-person lectures, we're putting information out there. We can make ways for our clinicians, our physicians to get CME credit for what we're trying to teach them. Sounds like there's a lot out there for me, which means that there's also a lot out there for for the listeners as well. And physician coaches, common thing for them to give CME credits to their clients. So you really have all of my listenership covered in terms of application. And so if I can't see not having this on my podcast. I'm currently moving and shaking with a lot of different moving pieces on it. But once I get things settled, I can't see not including CMEfy here. So keep listening and you'll be able to get CME credits for these episodes.
Yeah. And one of the things we push really hard on is the messaging around this. And again, I think a lot of the questions you had explain exactly why we need to concentrate on messaging for this. And what I mean when I say that is no one's earning credit for listening to your podcast. No one's earning credit for even attending a summit lecture that has CMEfy. No one's earning credit for going to that M&M round that's CMEfy. You're earning credit for reflecting on how it applies to you by attending that summit, by listening to your podcast, by going to that M&M. What you're doing is you're gaining access to the opportunity to reflect and earn credit. So again, our job becomes making it ridiculously easy for the host to pump out links and attach them wherever their learners and listeners and colleagues are, and ridiculously easy for the learners to click on that link, reflect, and earn their credit and manage it from that end. And we actually, it's Wednesday evening here. We are live pushing out probably our largest ever update, where it's a completely new user experience from the learner side and from the host side, taking some of those things that we've learned from our users, from our hosts, and some of the suggestions and some of the tweaks over the past 5 to 6 months, and putting it into a new update here. So what this is going to do is really put the onus on the host to bring the learners to that space in that context, and then on the learner to reflect and apply it to themselves. We don't accredit the content. We just bring you to the context and we let you engage with the concepts and reflect on them and earn.
So is there a limit to what we can cover, right? So some of my episodes, not many are clinical. Most of them apply specifically to the physician, but I might have an episode soon where I talk about opening your first Airbnb, right?
Yeah.
Jim Dolly, the white coat investor, had a whole summit, and some of his stuff might be medical, but a lot of it is like why you should invest in index funds. So what's the limit here on what we can CMEfy?
Yeah. I mean, that's something we've been working very closely with our CME partners. That's something that traditionally the CME world starts to shake when you hear things like that. And again, to give you the honest answer, yeah, you could, because again, we're not accrediting the content. We're accrediting the learning moment that's brought to it with the learner. However, the onus is on the learner to apply that to them in their clinical practice. If they can do that in a way that's beneficial to them and relevant, then they can earn credit. We're trying to respect some of those lines, and in a way that again, CMEfy is simply a digital platform, a technology tool that brings the learner to that moment. There are a lot of concepts.
Don't abuse it, or my kids, right? It circles back to the beginning with the kids. If you keep on hitting your brother with it, I'm going to take it away. You're going to lose this is why we can't have nice stuff. So, right. Don't abuse the system that you guys have helped to build that can really benefit us and make our lives easier in so many ways, or we're going to lose it. So, be a good community member.
Yeah, I think that's exactly right.
Yeah. All right. So where can we find you? Where do we find Dr. Brian Cohen? Where do we find Adapttrack and CMEfy?
So you can find me in the OR. Go search around. I'm pushing propofol usually. email brian@cmefy.com. We are on LinkedIn quite a bit. So that's the CMEfy page. Again, my own personal LinkedIn account. Twitter and Instagram, BD Cohen, the number 8. And, honestly, your listeners are the people that are finding benefit in this. We want to engage with them. We want to talk with them. We want to make sure they understand the whys and the hows. They can reach out to me by email any way that was listed. And we one of the most efficient ways is we have open demo sessions twice a week where anyone can sign up, come in, see the platform, see how it works, and really get signed up right there. So
great.
We look forward to seeing you guys.
Thank you. And thanks for allowing my listeners in the upcoming weeks to get CME credit for the content here. Thanks so much for your time.
Thank you, Brad.
That was Dr. Bradley Block at the Physician's Guide to Doctoring. He can be found at physiciansguidetodoctoring.com or wherever you get your podcasts. If you have a question for a previous guest or have an idea for a future episode, send a comment on the webpage. Also, please be sure to leave a 5-star review on your preferred podcast platform. We'll see you next time on the Physician's Guide to Doctoring.